Hello, folks, friends of the Retina Channel podcast. Welcome to another episode of this series. Today we have episode 81 of the Retina Channel podcast, and I'm very glad you joined me today in chatting with Dr. Marc Spirn from Wills Eye Hospital. Dr. Spirn is going to talk to us about the publication he recently produced with his group at Mid-Atlantic Retina and Wales on a series of patients that had laser retinopexy for high-risk lattice degeneration. And then he followed them for an average of 3 years and looked at the outcomes of how many did well, how many developed retinal detachment, and if the laser retinopexy could be any protective against unwanted outcomes. This is an area we don't have a lot of data on. Unfortunately, we don't know what's the best course of action for many patients with lattice degeneration. Some physicians go ahead with laser retinopexy, some don't, some do something in between. So I was very glad that Dr. Spirn and his team went ahead and published this article to give us more information about what to do with these patients, at least how to consult them and give them more information to make their own informed decisions. Well, Dr. Spirn, just give him some background about him. He did his undergraduate degree from Cornell University, his medical school in Rutgers Robert Wood Johnson School of Medicine in New Jersey. He did his residency at Emory University in Atlanta, and then he did a 2-year surgical retina fellowship at Wills Eye Hospital. He is now an attending in Wills Eye Hospital and Mid-Atlantic Retina since 2008. He's on the editorial board of Ophthalmology Times, has been a reviewer for many ophthalmic publications, and he's involved in teaching medical students and residents and fellows at Wills Eye Hospital. He is interested in many aspects of research in vitreoretinal disease, including retinal detachment, diabetic retinopathy, age-related macular degeneration, macular holes, macular puckers, and also complications of cataract surgery. I'm very thankful to him to come to the show and give us his insights about this wonderful publication that his group produced. Well, without further ado, this is Dr. Spirn. Hello, Dr. Spirn.
How you doing?
I'm good. How are you?
Good.
Welcome to Retina Channel podcast.
Thank you. I'm excited to be here.
I appreciate it. Thank you for taking time off your work. You know, it's the evening hours you're talking. I know you have some family obligations as well, so I really appreciate you giving me time.
My pleasure. My pleasure. How are you?
I'm well. Thank you very much. Well, busy as we are all the time, but you know, I'm excited to talk to you about this article you published about lattice degeneration and whether we should laser or not, and you showed some outcomes about your experience with it. I have to admit, when I read your article, it didn't answer any earth-shattering questions I had, but it was an avenue. It was something about a topic that we really need more information about, you know. So I really wanted to know, because as your article mentions, for decades we haven't had any data on what we should do about high-risk lattice degeneration. And you put out something, so I appreciate that. Thank you very much.
Thank you.
So your article, just for the listeners and viewers to know, it's a retrospective study of about, I think, 167 eyes that I think they were your patients, if I'm not mistaken, treated over a span of 7 years, who had lattice degeneration with some high-risk characteristics. And you looked at their outcome. You know, you looked at the rate of retinal detachment and retreatment with laser and things like that. And it gives us some more information about what to do. So I'm excited that we could chat about it.
Yeah.
Perfect. So just some background from your end, Marc. I mean, I gave my excitement about it, but what made you pick up this task and looking into this?
Yeah, so I think this is one of those topics where whenever you have a patient sitting in front of you, you kind of think, should I treat this patient or should I not treat this patient? And I'm in a pretty big group of doctors, and I feel like when I talk to my patients, they'll say, well, Dr. X said I could leave this forever, and Dr. Y said I should treat this. And then I'm looking at the patient, I'm like, well, what would I do? And, how do we make the best decisions when it comes to this? But I think this topic in particular is probably one of those topics where, there is a lot of controversy or uncertainty for clinicians when they're trying to decide, should I treat lattice prophylactically or not? So I was just curious, what my outcomes were. I probably tend to treat a little bit more liberally than some other doctors in my practice. So I was just sort of curious to see how patients did, and that's sort of what sparked this project.
So let's start with the patients you actually include in the study, and those that you treated. All of them were treated for lattice degeneration, and you designated them as some kind of a high risk, some reason for you to treat them. Can you name some of those or all of those? What was the sort of thresholds for treating those patients?
Yeah, so there was a number of different high-risk characteristics. These included things like retinal detachment or multiple retinal tears in the fellow eye, if they had lattice degeneration with a hole, especially if that hole had subretinal fluid, retinal tufts, vitreous traction or obvious vitreous traction on the lattice degeneration, or if they were getting ready to have a planned intraocular surgery, like cataract surgery, or retinal surgery, for example, like a macular pucker surgery, or removal of floaters. We did not include patients who were having vitreoretinal surgery where we knew they were going to need to have a PVD induced, like a macular hole surgery.
You did not include them.
We did not include those.
Okay. Because you would laser those intraoperatively, or?
Sometimes we would laser them prophylactically, but I think just the dynamics of what happens in the operating room where you're, lifting up the vitreous, I think it would be hard to tell how those patients did. And I think the efficacy of laser is a little bit different in that setting than, without going and taking your cutter and pulling on the vitreous over the lattice.
Gotcha.
When you're inducing a PVD.
Okay. And I noticed like almost 40-50% of all these patients had a fellow eye detachment, correct? So there.
It was a pretty high number of patients, had fellow eye detachments.
Okay. How about myopia on its own? Was that one of the risk factors? No.
We don't have access to that data. So in our charts, we don't have refractions in our charts. So presumably many of these patients were myopic, but we don't have access to their actual refraction.
But you didn't pick myopia as a risk factor to do laser. It usually had something like a hole or subretinal fluid, fellow eye attachment, those things like that.
Yeah. So, this was a retrospective study, so we were sort of limited by what was in the chart.
Yes.
Although, prospectively, when I'm seeing a patient, if they are a high myope, particularly if they're undergoing cataract surgery, that is a factor I would consider.
Gotcha. And does the extent of the lattice make a determination on your decision? I tell you my story. Sometimes I have a patient and they have like almost 360 degrees of lattice. And then there may be a bit of a hole or a partial hole in part of the lattice, or they may be going LASIK surgery coming up soon. Sometimes I don't know what to do with it. Like it's a lot of lattice. If I'm going to laser that's 360 degrees of laser. So sometimes those times I just laser the holes, or just tell them this is what do you want me to do?
Yeah. So, I know it's not an easy question, and I'd struggle with that myself. I can tell you that over the years of doing this, my technique has changed, how I laser lattice, the extent of lattice, who I treat. So this study started, I think, in 2014 and went through 2021. I started practice in about 2008. And I would say over the years, I've sort of shifted a little bit. When I have a patient sitting in front of me, I always think to myself, if they have a pre-existing PVD, they're probably lower risk of having a problem. They may not be zero risk, but they're certainly lower risk. And I think we saw that in this study as well, that, many of the complications of post-lattice laser were subsequent to PVD. Either they developed an ERM, most of those patients had PVDs, they developed a retinal tear or retinal detachment, those patients developed PVDs. So I think now when I'm thinking about prophylactic laser, I'm more inclined to do that if they don't have a PVD. If they have a PVD, then I'm looking for, really high risk factors like holes with fluid, a lot of traction, things like that. And then, in terms of how much laser you treat, that was hard to sort of suss out in our study. Just going through the charts, it's based off our drawings and what we, in the extended exams and our notes. But so that data is a little hard to suss out, I think, in a retrospective study.
Fair enough. Fair enough.
But I think it's sort of, at least in my mind, it depends a little bit about just sort of the clinical situation. What happened to the fellow eye? Did they have a GRT? Did they have, like a detachment? If they had a detachment or some sort of abnormality where there was a lot of vitreous space traction, I'm more likely to treat, 360 or around the lattice.
Yes, makes sense. It's very individualized. Like every patient is different, really, when it comes to this. Okay.
Yeah. And I do, one thing that I do in most of my patients is I also try to bring the laser close to or to the ora serrata unless they have real posterior lattice. So I'll surround the areas of lattice.
Yes.
But then I'll usually bring the laser out toward the ora.
Oh, okay. Like
Just
a little
maybe
horns
not
to the
confluent.
aura. Okay.
Yeah, maybe not confluent laser to the aura, but I'll do like a tight PRP. And I think when you look at the outcomes in this study, there were 5 patients who developed detachments in areas outside the laser.
Yes.
4 of those were treated with laser. 1 needed a buccal vit.
Yes.
But there were 11 patients who developed tears inside the laser who never progressed. So, that may have been because the laser was brought anteriorly enough that it didn't rip through the anterior laser.
Gotcha. That's a very good point. Someone else years ago told me that they lasered the lattice and they extended from each end of it a little more than where the lattice ends. And that because most of these tears after PVD, they happen at the ends of the lattice patch.
Yeah.
So, but you go around the lattice and you extend it like two little horns to the aura. That's a good technique.
Yeah.
Okay.
Yeah. Or I'll do like a PRP along the whole backside of the,
just fill that area or just
yeah. But I do make sure that the horns are out to the aura and pretty good anterior coverage.
Okay. Okay. That's very, very good. Okay. So you mentioned that the outcomes, and that's we want to know. And these patients, I think they were followed average of 3 years or so, if I remember correctly.
Yep.
And then, so you had 5 detachments of these patients who were treated. 4 only needed laser. So these are focal detachment, subclinical, I imagine. That's great.
Yeah.
1 had a vit buckle, 1 just 1 surgery.
Yep.
And then you had some ERMs. And could you talk about that, please?
Yeah, I think the majority of patients who had ERMs were older patients, and there were also patients who were more likely to have developed PVDs afterwards.
Yes.
Yeah, I mean, I think at least from what I've noticed, ERM is a pretty unusual complication of laser retinopexy if the patient doesn't develop a PVD. I'm not sure that we had any that were without PVDs in our group. So, whether that was from the laser or the PVD, it's hard to say. My guess is it was probably the PVD that instigated it, but who knows? And then, the big outcome we were expecting to look for was just tears, detachments. One thing that I tell my patients in the office is and one of the reasons that this is controversial is that we do laser to the lattice, and sometimes people will develop tears in locations that we didn't laser.
Yeah.
So that was one thing that I was curious about. And I think in our study, I think we had 16 patients who developed tears, I think. And I think 11 of them were inside the laser lattice and 5 were outside. So that gives you at least a little bit of a idea of where these tears are occurring.
Yes.
when
Yes.
they do develop PVDs. But it
Yeah.
also lets you know that you need to follow these patients and let them know about the signs and symptoms of, vitreous detachment and retinal detachment.
Okay. So, is it safe to assume all these 16 patients, the tears happen after the PVD?
Correct.
Okay.
Yeah.
So that's a high percentage. Like out of 167 eyes, 16 develop tears.
Hmm.
Um,
Yeah.
and I'm sure that not a whole 167 were people. Some of them had already PVD, so they
Right.
go out of question. So
Yeah.
there some who didn't have PVD, they developed PVD, and a good chunk of them developed tears.
Yeah. I can't remember
And
the exact number, but I think 40 something patients had PVDs at the initiation of the study.
okay, so
So
120 or so did not have
yeah.
PVD, and 16 developed
Yeah.
tear. So it's just about 15% or so developed
Yeah.
a tear, and
Right.
majority were actually captured by the laser that was already done.
Correct.
But this is very
Yeah.
good. I think that's
Yeah.
actually that's reassuring that
Yeah.
you could contain a lot of tears.
Yeah. Yeah. I mean, I think this is one of those topics that's a little, again, the uncertainty is there because, if you just do sort of a natural history study on patients with lattice degeneration, only maybe 1 to 2 to 3% of those patients are going to develop retinal detachments. But if you
Yeah.
sit in our office, we have retinal detachments coming in all the time. And
Yes.
probably, 30 to 50% of those retinal detachments will have some degree of lattice degeneration.
Yes.
And in my experience, that lattice is at least somewhat causative in the
Yeah.
majority of those patients, whether the tears in the lattice or, it's associated with it. So, um, you know, it's a
Hmm.
it's an interesting topic.
Yeah. And those five detachments, were they because of tears as well, or because
Yes.
of, okay, they were because of tears
Yeah.
as well. So any of those tears were within the lattice, or they're outside the area? Because I'm curious, how come they were contained with just lasers? So they were captured early, or how come they were not that
Yeah. So they
advanced?
were outside the lattice. They were new
Yeah.
tears outside the lattice, but um, I I think we try to do a pretty good job of just letting people know the signs and symptoms. I think a lot of these patients who are undergoing prophylactic laser are a
Hmm.
little bit more aware that they're
Yes.
higher risk.
Hmm.
So we
They came
sort
on time.
of,
Yeah.
yeah, we drill into them, new floaters, new flashes. You got to give us a call. And a lot of them caught them even earlier, right? We caught them at the stage of a tear. The ones who
Yeah.
detached, maybe we caught them a couple days later, but still, pretty early.
Very good. You get your
So,
fellows working hard
yeah,
at Bill's.
for sure. For sure.
Yeah, amazing. Okay, so what do you want us to remember, Dr. Spirn, from your article? What's your takeaway message?
Yeah. So the take home message from this paper is lattice generation is a prevalent cause of retinal detachment. Laser retinopexy appears to be a safe procedure in its current iteration. But even when laser retinopexy is performed, these patients still need to be followed
Hmm.
longitudinally. So these aren't patients. If you have a patient who comes in with high risk lattice degeneration and you're treating it,
Hmm.
you probably shouldn't treat it and say, go back to your, regular ophthalmologist, or I never want to see you again. These are probably patients who should be watched periodically because they do come in with complications sometimes a year, 2 or 3, 4 years down the road.
Hmm.
Um, and if you catch them early, you may be able to intervene and treat them with either more lattice or more laser and prevent a detachment that needs incisional surgery.
Okay. I imagine, especially if they haven't had a PVD, and the risk of
Yeah.
having PVD like mid-age or 40s and 50s, are
Right.
probably that's the age they can get trouble. But
Yeah.
other than the detachments and tears, you didn't have other complications like ERMs on their own or without the PVD, or you didn't have
Right.
any major issue,
Right.
or photopsia as
Yeah.
was.
We didn't see CME. We
Yeah.
didn't see choroidal detachments. We didn't see any immediate retinal detachments after laser.
Yes.
Those are rare complications that I've seen, over the years, but not in this study.
Yes.
So
Um, And I imagine, and you mentioned that in your discussion, that ideally you would have an untreated arm, the same group of patients with those high risk lattice patches that you,
yeah,
and you would compare them after 7 years. But I guess that's an ideal world.
Yeah.
You won't know that. Like
Yeah.
how many of those get detachments.
Yeah. Yeah.
But
And I
this is
think
first
that
step.
data probably exists. I do think there are doctors who, regularly watch some of these patients. They have a retinal detachment in one eye and they see
True.
lattice and they watch them. We were trying to control, at least for the surgeon factors we could. I do my laser, kind of the same way every time. And I think some people do it differently, and whether that influences outcomes, we don't know. But
Yeah.
we were just trying to control for some of those factors.
Yeah, it gives us information. I mean, some of them like high risk, some high risks are for high risk for anyone. Like to me, fellow eye detachment, I would laser any lattice in the eye, whether there's
Yeah.
holes or not, Um, but if you watch them, and what happens? I've seen people watching them as well, as you said. So,
Yeah.
um,
Yeah.
wonderful. Well, I really
Yeah.
appreciate it, Dr. Spirn. Late night, you coming on the Retina Channel podcast, giving us your expertise and your wonderful work with this, and giving us more knowledge and shedding more light on something that's still murky, but gives us more information now.
Oh, I appreciate it.
Thank you so much.
Yeah. Thanks for having me.
Pleasure. Well, friends, this wraps up episode 81 of the Retina Channel podcast. I hope you learned from this episode. I want to thank Dr. Spirn again and his group for shedding some light on this fairly murky topic of lattice degeneration and what to do with it when we have a high-risk patient for retinal detachment. It's not the final answer for this type of question, but I'm very thankful that his group produced some more data about this topic. A bit of a heads up about our next episode is going to be with Dr. Salabati, and he is going to talk about another surgical topic, which is the use of perfluorocarbon liquids for macula off retinal detachment and the effect of using high density perfluorocarbon liquid versus not using it on the post-operative metamorphopsia for macula off retinal detachment. So his group looked at some patients who had the perfluorocarbon use during surgery and some who didn't, and they compared the metamorphopsia post-operatively. He will join me from Ivory Coast, which is the first time we have a guest from Africa, although the work is done in France, but he is now located in West Africa, and I'm excited to have that conversation with him as well. Well, until then, have a nice day, take care of yourselves, and we'll talk later.